Uh, I enter into this virtual space with immense empathy, not only as a breast cancer medical oncologist, but also as a motherless daughter, having lost my own mother to metastatic breast cancer in 1991. So I very much understand the impact of this disease, its impact on caregivers, family, friends, and communities. And my goals over the next hour here that we're together are to provide you with a very high-level overview to metastatic breast cancer, specifically to help support those who have a new diagnosis of metastatic disease, to empower all women and men with metastatic breast cancer so that they can advocate for their health and their care, and importantly, most importantly, to provide a message of hope. So I'm going to break this talk into 4 components. Initially, talking about the diagnosis, second part about treatment, the third part about supportive care, and the fourth part about some of the current issues we are facing. After each one of these components, we'll take some time for question and answer, so we hopefully can make this as conversational as possible. So with that, I'll go ahead and dive in with some straight talk here. First, starting with what is the definition? What is metastatic breast cancer? Metastatic disease is a systemic disease, meaning spread of the breast cancer has occurred from the primary tumor in the breast or the local lymph nodes to other organs in the body. And potentially any organ can be affected by metastatic disease. And we call it systemic because the spread occurs through the bloodstream. And so when these cancer cells are present in the bloodstream, they're able to seed and spread in the body. And we'll come back to why that's important, because our treatment is really focused on the fact that metastatic breast cancer is a systemic disease. About 10% of patients with a diagnosis of metastatic breast cancer had no prior history of breast cancer, and we call this de novo disease. We often treat it very similarly to the majority of patients who do have a prior history of breast cancer. So 90% of those with metastatic breast cancer had prior treatment for original early stage disease confined to the breast and sometimes local lymph nodes. Most patients received optimal therapy, the right surgery, the right radiation therapy when that's appropriate, chemotherapies, endocrine therapies, etc., for their original early stage breast cancer. And it's never the patient, never you, that failed these treatments. It's our very best treatments that failed you. It's uncommon that metastatic breast cancer is curable. I've learned never to say never over the course of my training and my career. I think increasingly we are seeing women live longer and longer with the disease and living with a better quality of life with the disease. And we really consider it a chronic condition for which we are fortunate to have many different treatment options. But I'll start again focusing initially on the diagnosis. It's often signs or symptoms that bring the diagnosis to attention, often picked up on scans, CAT scans, or a PET CT scan or a bone scan. But really, a biopsy is the most important diagnostic test that we perform. We've learned never to assume, even in a patient with a history of breast cancer, when we see new findings on a scan concerning for metastatic disease or spread, it's always important to biopsy. There's a few reasons for that, but most importantly, it allows us to conduct specific tests on tumor cells that help give us information about prognosis, and most importantly, they help us guide treatment. There are 3 different biomarkers, which are really just proteins that we are evaluating on the cancer cells, breast cancer cells, including the estrogen receptor and the progesterone receptor, and we commonly refer to those as the hormone receptors. And then the third is the HER2 receptor. And these two different pathways, so the hormone receptor is a pathway by which estrogen can fuel breast cancer to grow. The HER2 receptor also stimulates the HER2 pathway, which is a different way by which breast cancer cells can grow. And these are the most commonly recognized pathways for which we're very fortunate to have treatment options specifically for them. So we think about, again, in terms of prognosis and treatment decisions, three different molecular subtypes of breast cancer: hormone receptor positive and HER2 negative. The second being HER2 positive breast cancer, regardless of the hormone receptor status. And the third being hormone receptor negative and HER2 negative breast cancer, which is also commonly referred to as triple negative breast cancer. Quite frankly, a term I don't like because we haven't found the positive yet. Also more commonly performed now as part of diagnosis specifically for metastatic breast cancer is tumor sequencing. And this is a test by which all the different genes, or a very large panel, hundreds and even thousands of different genes in the tumor, not the genes that we pass on through our family, but these are the genes in the tumor, where we look for different mutations in some of these genes. Sometimes when we find one of these genes that in addition or in lieu of the hormone receptor and HER2 receptor, some of these other gene mutations can be drivers for growth and spread of the cancer. Sometimes when we find these gene abnormalities from tumor sequencing, we may have an FDA-approved drug that can target that specific mutation. Sometimes we have an investigational drug that's available in a clinical trial. Sometimes we're not sure what to make of whether or not a mutation is actually a driver for cancer. And sometimes we have these mutations, but no therapies yet available. But again, commercial insurance and Medicare, Medicaid are often paying for this testing now, and I'd say within the last couple of years, it is very routine now for this type of testing to be performed. And then finally, genetic testing. And this is actually testing the genes that we do pass on through our family. And we evaluate through genetic testing, often a blood test. We're evaluating for the presence of a mutation that's known to be associated with a hereditary cancer syndrome. Most oncologists now are advocating for all patients, especially those with metastatic breast cancer, to undergo genetic testing. And the reason why is because we now have some FDA-approved therapies for some of the specific gene mutations, such as those in the BRCA1 and 2 gene. There's also some clinical trials available for patients who have these hereditary cancer syndromes. And it goes without saying, there could be potential implications for other family members. So I'll pause there, and we'll take a little bit of time for some question and answer related to this topic.
So yeah, we have a few questions. So the first question, and thank you for your information, it was really great. What are some of the most important questions related to diagnostics people should ask their physicians?
Yeah, that's an excellent question. I think probably one of the most important things is related to the biopsy. And the reason why is that is the information that your oncologist will use to formulate all your treatment plans. And so sometimes if there's any question or things just don't seem quite right with the pathology analysis, it's good to get a second opinion, including a pathology second opinion, perhaps at another institution. There's so much, again, that emphasis and need to have accurate biopsy information to drive treatment decisions. So I think that is probably one of the most important things in terms of all the different diagnostic tests that we do.
Okay, awesome. Another question we had was, in your time as a physician, what has felt like the most important advance with the diagnostics? And what do you see coming next? And what do you think will help the patients?
Yeah, I think, I spent some time talking about the genomic sequencing of tumors. This has probably been one of the greatest advances just in recent years. And as I mentioned, it really hasn't been up until the last couple years where it is becoming just routine and commonplace across the country, around the globe, to have the tumor specimens sent, either sent out to a different lab, or some institutions have the ability to do it through their own laboratories. But the reason why I think this is such an important advance is because it gives us such a more comprehensive understanding of the tumor. Knowledge is power. And so the more information I know about the tumor, the more effective I can be in terms of recommending different treatment options. And the more effective those engaged in research can be, developing new drugs and new therapies targeting these mutations. So I think just from a research perspective, as well as clinical care perspective, this has been hands down one of the greatest advances, because increasingly the other thing we're learning is that sometimes gene mutations that we see in breast cancer may be more common or present in other types of cancers, like a melanoma or lung cancer, as just a few examples. And so that again is allowing us to provide more individualized treatment options and treatment recommendations, because the recommendations we're giving are based on the unique features of your specific tumor.
Awesome. So that's all the questions we have for this portion. I guess we can move on to the next.
Sure. So during the next portion here, we'll talk a little bit about treatment. And coming back to a few of the things that I previously highlighted, again, keeping in mind that metastatic breast cancer is uncommonly curable, our goals of care for metastatic breast cancer must keep that in mind. Our goals of care then are to be able to control the disease. So ideally, we can provide treatment that shrinks the cancer, and sometimes it can shrink it all the way to the point we can't visualize it anymore on our scans, CAT scans or PET scans. But sometimes we'll accept stable, as long as the cancer isn't growing or spreading further. Sometimes stable response is good enough, especially when the cancer itself is not causing any symptoms. So that's one of the goals. One of the other goals is to be able to control the symptoms of the disease, whether it's pain from bone metastasis, whether it's suppression of appetite and weight loss or nausea, whether it's cough or feeling breathless. Our treatments are really targeted to help suppress the cancer, shut down the activity, and be able to shrink the disease. And typically, if we're able to achieve that, we can control the symptoms of the cancer. And then importantly, our goal is to prolong life with the best quality of life possible. We really think of treatment in our goals of care. Again, we have to find that balance between the benefit, stabilizing the disease, and the risks or toxicities of disease. The cornerstone for treatment are our medical therapies or systemic therapies. And again, that comes back to the point that metastatic breast cancer is a disease that can affect any of the organs in the body, head to toe, and it does so by virtue of spread through the bloodstream. So it's so important for us to make sure we have anti-cancer or cancer-directed therapies in the bloodstream more or less at all times. again, coming back to this being a chronic disease as well. Our treatment options are really focused on those different growth pathways that I had also mentioned previously. So for women with hormone receptor positive disease, our treatment options are really aimed at disrupting estrogen binding to the estrogen receptor present in the cancer cells. And so often our therapies or anti-estrogen therapies are again, the goal is to disrupt that interaction because that's what stimulates or can be a pathway to stimulate the cancer cells to grow. Now often for the men and women with metastatic breast cancer that is hormone receptor positive, in recent years, advances I'd say over the last 4 to 5 years now, we have approved therapies called targeted therapies that we combine with our endocrine or anti-estrogen therapies. These targeted therapies, at least as of today, there are about 5 that are FDA approved. They are really meant to target some of the pathways, different pathways in cancer cells that can cause those cells to become resistant to our anti-estrogen drugs. So it's often the combination of the endocrine therapy with the targeted therapy that we have found to be more effective than the endocrine therapy alone. For HER2 positive breast cancer, we're also very fortunate to have several approved drugs that are targeted specifically for that HER2 pathway. Most of these drugs are antibodies, just like we make antibodies to fight infection. These are antibodies that target the HER2 component of the breast cancer cells. Some of these antibodies have chemotherapy linked to them, so we can directly deliver chemotherapy to the HER2 positive breast cancer cell without having chemo circulating in the bloodstream. So typically fewer side effects, and we're very fortunate to have the second one of 2 drugs just FDA approved earlier this year. That is, we call them antibody drug conjugates. And then we also have some oral inhibitors of HER2. The third broad category is our oldest form, one of our oldest forms of cancer-directed treatment being chemotherapy. And again, we're very fortunate for metastatic breast cancer to have a long list of different chemotherapy drugs that we can prescribe. They have different mechanisms by which they work. They have different side effect profiles, different response rates, and we take all those things into consideration when we pick one over the other. It's also important to know that combination chemotherapy, meaning 2 or more drugs, is not more effective than a single drug. So typically we use chemotherapy 1 drug at a time. And then the fourth main category is immunotherapy. And immunotherapy has been around for cancer for nearly a decade. But it wasn't until just the last couple years that the first drug was approved for metastatic breast cancer, and specifically hormone receptor negative, HER2 negative, or triple negative metastatic breast cancer. And immunotherapies are really medications that are aimed to activate our immune system, and so that our immune cells no longer tolerate the disease, but rather recognize it as foreign and help our immune system to actually eradicate the cancer cells. And we're excited because we are studying the immunotherapy for the other subtypes, molecular subtypes of metastatic breast cancer, and our clinical trials are showing some encouraging results, and we hope to have those agents available to all patients with metastatic breast cancer in the future. But all of those drugs and different medical therapies that I just mentioned all came to be available because they were first evaluated through clinical trials. And I want to be sure to emphasize to all of you the importance of clinical trials potentially for your own care, not just to advance the science and help us achieve our research goals, There's actually a study that was performed in women with early stage breast cancer that showed women who participated in clinical trials actually lived longer than those who did not. I suspect the same might be true in the setting for metastatic disease as well. Clinical trials really offer tomorrow's most promising therapies to patients today. And so there's a very rigorous science behind the evaluation of these new therapies in clinical trials. So I encourage all of you to talk to your oncologist about clinical trials every time there is a need to start a medical therapy or change to a new medical therapy. And if you receive care at an institution where they do not have any clinical trial opportunities, seek out a second opinion at another institution that could offer clinical trials. My last comment is just regarding the role of local therapies in the setting of metastatic breast cancer. We've learned from research that if a woman has their original breast tumor or the primary breast tumor still intact in the breast, in the setting of metastatic disease, there's no benefit to having surgical removal of the tumor. So we typically do not recommend surgery or radiation for the primary tumor because it has not been shown to improve long-term outcomes. Now, there are some exceptions to that. Certainly, if the tumor is causing pain, we would do surgery or intervene to help alleviate any pain. Similarly, we typically do not treat any single metastatic sites of disease with local therapies like surgery or radiation, again, unless they're causing symptoms. And sometimes in some uncommon, but certainly scenarios where there's only a single metastasis or perhaps two, that is sometimes a setting where we would be more aggressive, if you will, with surgery and radiation therapy. And then finally, brain metastasis, when breast cancer spreads to the brain, that is a time where we would sometimes, I wouldn't say sometimes, where our primary treatment modalities are actually radiation or surgery. So I'll pause there and make sure we have some good time for questions regarding treatment.
Yes, we did have a few questions flow in. That was a really informative section. When you were speaking of clinical trials, we did have a question on if there's an age limit for qualifying to be on a clinical trial, and if it isn't, can you still do things of normal activity, work, and family, all these other responsibilities while on a clinical trial?
Great, that is a great question. So typically there is an age minimum for our clinical trials requiring adult age 18 or older. But I don't know that I've ever seen a protocol with an upper age limit. So thankfully, there really is no discrimination based on age. We absolutely want people to live their life as fully as possible while participating in a clinical trial or just globally, not even if they're on a trial. The thing that's sort of unique about clinical trials is that the protocols that are really put in place first and foremost for patient safety will have some specific requirements about the timing for the treatment, for assessments by the oncologist, for specific blood work, when to do the scans, etc. So there's a little more rigidity in the schedule as opposed to treatment off of a clinical trial.
Thank you for that. Another question we had is, when you are on the hormone receptor positive medications and your MBC and you fail those targeted plus the hormone therapy, why would that happen?
Great question. So first and foremost, patients don't fail. our drugs fail you. And so I'm such an advocate for that language, and correct my colleagues if I hear that language too. But we know that cancer cells can become resistant to our different endocrine therapy or anti-estrogen therapies. The way I liken it is very similar to us when we have infections, you know, bacteria or virus infection, and we use antibiotics. You know, over time, the bacteria or the virus wants to survive and will learn how to overcome and grow and survive in spite of antibiotics. Cancer cells, especially metastatic cancer cells, are similarly hardwired, where they want to survive, and they will find new ways to survive in the setting of really most of our cancer treatments, not just endocrine treatments, but sometimes our HER2-directed therapies or chemotherapies. So typically what happens in that situation is different growth pathways or survival pathways in the cancer cell will take over. Sometimes in this setting, the cancer cells will have a new mutation or acquire a new mutation that can drive the cancer cells to grow. One thing that we know can happen, and actually it is increasingly common now for us to rebiopsy metastatic disease multiple times throughout the treatment course, because we know that sometimes cancer cells that were initially estrogen receptor positive can become negative, and that's one means by which they become resistant. Similarly, one of the ways by which they can grow is to now overexpress or become HER2 positive. So it's not uncommon when a change in therapy is needed, or sometimes on a scan we'll see one area get better in the body, but in a different organ things get worse. And so sometimes it is helpful to rebiopsy and see if there has been a change in the biology that might direct a change in treatment as well.
Excellent. Another question, there's so many good ones that's coming. Is there any type of assistance with the clinical trial paperwork? And at what point in treatment is being on a clinical trial a good idea?
Yeah, that is such a great question. So often there's, I always say that one of the benefits to being in a clinical trial is your team grows larger. In addition to your clinical care team, you'll have a research team. And often the research study coordinators or study nurses can assist with any needed paperwork. As to the question, when's a good time? I say every time a treatment is going to be started, you should ask. Sometimes we are evaluating some of our most promising drugs right up front, meaning with the very first initial treatment for metastatic disease. And so it really, at any point in the journey, I think it's important to ask about clinical trials. It's definitely not something you have to wait for until we've exhausted options. Notably, sometimes clinical trials will actually require that you had not received chemotherapy for stage 4 disease in order to be eligible to participate. So again, sometimes even more upstream, during initial diagnosis or perhaps after the first treatment. So really, again, at any time, a clinical trial may be an option. So this next section is going to focus a little bit more on supportive care, quality of life, and wellness. And I'm intentionally going to try and keep my comments brief so that we can make sure we have ample time for questions and answers related to this. When we think about supportive care, these are really sometimes medications, sometimes radiation therapy, or other interventions that are really targeted at improving quality of life. For symptom control, sometimes we're trying to help alleviate symptoms with the cancer, or sometimes it's helping to manage side effects from cancer treatment. Some of the different symptoms that we are commonly helping to alleviate would be pain, menopausal symptoms, very common really with most all of our cancer-directed therapies, but especially the anti-estrogen therapies, things like hot flashes, vaginal dryness, or joint stiffness and achiness. Gastrointestinal changes, whether it's issues with nausea or constipation or diarrhea. Mouth sores can be a side effect with some of our oral targeted therapies and some of our chemotherapy as well. And fatigue, probably one of the most common symptoms of the cancer, but also side effects from treatment. I think it's really important to know or be aware that palliative care and palliative care specialists are form a wonderful triad between the oncologist, the patient, and having a palliative medicine specialist involved. They are experts in managing symptoms. And every time I work with my colleagues and collaborate with our palliative medicine colleagues, I learn something new. They really are up to date on all the research and novel ways in which we can help manage symptoms. We've actually learned from some clinical trials in other types of cancer, like lung cancer, that early involvement, meaning even at the time of diagnosis, having a palliative care specialist involved in care actually improves survival. So really important, don't think of palliative care as just hospice or something that we reserve for end of life. They should be engaged in care to help with symptom management all throughout the journey. Bone health in particular is important, especially trying to keep the bone strong, prevent fractures for patients who have bone metastasis, but also those receiving anti-estrogen therapies. Mental health, it goes without saying, with an initial diagnosis and potentially throughout the entire course. Depression, anxiety are common. You're not alone. There are so many great mental health resources out there. If you're not able to get help through your oncology office, I encourage you to speak with your primary care provider as well, whether it's counselors, social workers, support groups, many great options and opportunities. I always like to make a comment about sexual health specifically. Oncologists are frequently uncomfortable talking to our patients about this. Sexual dysfunction is very common in patients with breast cancer. So because the oncologist is frequently not going to bring it up, I encourage you to bring it up if you are experiencing this. There are some great local therapies that can be used for severe vaginal dryness, pain with intercourse. If your oncologist doesn't know how to help you, again, reach out to your primary care provider or request a referral to a women's health specialist or a sexual therapist. So some other things, what can you do if you have metastatic breast cancer to help with symptom control? The most important thing is remaining or increasing physical activity. There are numerous research studies that have shown that women who are physically active have less fatigue, better quality of life, better sleep quality, less anxiety and depression. I think it is good for a million reasons, and if there's one thing when women ask me, what can I do? This is the most important thing. And we're not talking about CrossFit training, we're just talking about a good brisk walk in shooting for about 30 minutes as the body tolerates each day. If you smoke, stop smoking. It is so much easier said than done. Talk to your oncologist, ask for referrals as needed there are many great aids for smoking cessation. It actually improves survival. It also lessens some of the toxicities associated with cancer treatment. When it comes to nutrition, I wish that I could prescribe a specific diet that could help with outcomes, but there really isn't a magic bullet when it comes to nutrition. The one thing that we have learned from research, though, and I think this is an important message, is to be mindful about different vitamins, antioxidants, and supplements. Some of the research, even probably one of the largest and best studies ever performed, was just published earlier this year. Granted, it was in women with early stage breast cancer, but it showed that when they took these different antioxidants, things like iron, vitamin B12, omega fatty acids, they actually had a higher risk for recurrence and shortened survival. And I suspect the same could potentially be true in the setting of metastatic disease. We don't know about all the different interactions with chemotherapy or any of our cancer-directed therapies. So I didn't know this particular topic. I have to say I've always been a huge advocate for integrative medicine, and I still am, but I encourage you to have some frank conversations with your oncologist about this specific topic. I think some may be reasonable, but you know, as the research evolves, we just need to be mindful about this. But other integrative therapies I think are wonderful, like yoga and meditation and acupuncture. I think they can be great adjuncts. Faith and spirituality, those communities can do wonderfuls for the mind and soul. Stay social. Have open dialogue with your family and friends. They may feel uncomfortable. They may even feel like they need to distance from you. So talk to them. Don't be afraid to talk to them. Everyone copes differently. You will notice other men and women dealing with metastatic breast cancer will cope differently. Family members all cope differently. Communication is key, and compassion for one another is key.
How do you figure out which type of physical activity that is safe for you to do while you managing bone metastasis?
Yeah, that's a great question. So I do think it's good to ask permission, if you will, for, I'd say, most activities that have more impact, that are higher impact activities, or certainly any contact type activities, or downhill skiing or horseback riding. You may want to talk to your oncologist just to understand what your risk for fracture might be. But generally speaking, actually, I'd say it's uncommon for us to prohibit specific activities, including things like skiing and horseback riding. So I say, again, listen to the body. No need to push oneself, but also no need to restrict oneself the vast majority of the time.
Yes, totally agree, because I like to snowboard, and it took me 2 years to get approval to be able to snowboard because I have mets on my hip, but I could do it now. Time and patience, people, time and patience. Another one is, how can we help our caregiver cope? What can they do to help support them? Yeah,
I think that is a wonderful and very thoughtful inquiry here. You're right. I think our caregivers, really for any disease, are often unsung heroes, and often will sometimes carry the weight of the world and burden silently. I think it's good to have frank conversations again with them. Understand how they're coping, if they are experiencing anxiety and depression. So there are some support groups that are out there to try and help caregivers specifically. But I think that, the key things are just making sure that they're taking care of themselves as well, doing all their preventive health measures, if they have chronic conditions, that they are seeking care for those. So I think both physical and mental health for our caregivers, and again, good communication is key.
Yes, exactly, because sometimes they really need that extra support with family and just understanding. How do you find a palliative care specialist, especially if you're in an area with lack of access, a smaller cancer center, or they just not have them on staff?
Yeah, that's a great question. I think, there are opportunities. Increasingly, cancer centers understand this is such a important aspect of care. And even when oncologists are unable to deliver on this, oftentimes this is where a partnership with primary care can be a win-win, if you will. And so sometimes, oncologists, for better or worse, are so focused on keeping the cancer contained, controlled, and will be more treatment focused as opposed cancer-directed treatment focused as opposed to supportive care focused. So I would say engaging primary care can be of benefit. Talking to other, peers through support groups to see some of the things that they have tried or used for supportive care measures, and bringing that information back to your doctor. And it may not be, here I'm saying doctor, but I think, if I'm frank, I am often going to my nurse practitioners and nurses. And often they are taking care of all cancer types, sometimes not just specifically breast cancer. And so they learn some tips and tricks, if you will, for symptom management in other cancer conditions. So sometimes a good time with a nurse as opposed to your doctor, you may get some great recommendations as well.
All right, and one more question for this session. It's been coming up pretty frequent. Is alcohol okay occasionally, or what is your thoughts on that?
Yes, this is such a great question. Research has been all over the place, saying no alcohol is best, a little alcohol is okay. I don't think in this situation we have research to tell us one way or the other. I guess I would say my personal opinion is more this. Again, when we think about goals of care, everything is about maintaining the best quality of life for as long as possible. And for some, alcohol, whether it's a glass of wine or whatever it might be, is part of family dinners, in social gatherings. And my opinion then is that it's okay to have everything in moderation. I don't foresee that it would cause any long-term detriment, again, as long as it's used in moderation.
Another question is, in the category of supportive emotional health, do you have any thoughts on how to help young children understand metastatic breast cancer?
Yeah, that is such a great question, and it goes without saying, it totally depends on the age, but there are some resources. I think that speaking with a counselor, sometimes our different psychologists or mental health experts can help with recommendations regarding whether it's a book to help you navigate the conversation. Otherwise, talking to the child's pediatrician and potentially having referrals through the pediatrics for peds mental health specialists and counselors to help facilitate some of these dialogues and discussions. So those are a few different ways to go about it. But I think one of the important things is just frank, honest communication with children, and especially as they get older. As a mother myself, I know I also underestimate what my children know. But don't be afraid to have a frank conversation. I think it's really important for them to understand what's going on and to feel listened to. I know it's easy to want things to seem normal as possible, and we don't want the burden of the disease to be passed on to them. But again, I think they want to be part of the conversation, and I guess I can say this even, myself, a teenager when my mom was diagnosed. That frank, candid conversation is empowering and helped me make decisions as well. So, yeah, thank you.
Yes, thank you for all the questions that we have received. I have one last question for you now. In regards to diagnostics, why do the same mutations sometimes show in a breast cancer and in other cancers?
Yeah, that's a great question. I think, increasingly we are learning that some of these different pathways by which cancer cells grow, survive, and spread are not necessarily unique to where the tumor began, the primary tumor, but that they're more broadly applicable across all tumors, or sometimes a handful of different tumor types. I really do foresee a future where, regardless of the site of origin of the disease, we will be using those things like tumor sequencing. We'll better understand more of the different gene abnormalities. We'll probably have a better understanding of different, how our immune system does and does not engage with the cancer, in developing new immunotherapies as well. So I think the bottom line is we know that each individual tumor is just as unique as the DNA that distinguishes all of us from one another. I think every tumor is unique to the individual. We're all our N of one, so to speak.